So, greetings and welcome to today's educational program, Process Improvement in Client Access to Care, using Design for Six Sigma from a Provider Perspective, by Robin Kelly and Shoba Mittal. This is your moderator, Doug Wood, with ASQ's Quality Management Division. So today we have a distinct pleasure of hearing from Robin Kelly and Shoba Mittal. Please join me in welcoming them. Robin Kelly has over 30 years of quality experience in various industries, from manufacturing to construction, and now in healthcare. She currently serves as Vice President, Research, Quality, and Compliance with Wesley Family Services in Pittsburgh, Pennsylvania, where she is also the HIPAA, H-I-P-P-A, that's, Portable Information Act, Privacy Officer, and Risk Manager. Robin received a master's in master's in public management from Carnegie Mellon University and participated in doctoral studies in organizational leadership with the Chicago School of Professional Psychology. Ms. Kelly is certified as a manager of quality and organizational excellence with the ASQ. She's also a certified investigator for the Pennsylvania Department of Human Services and is certified in compliance with the Healthcare Compliance Association. Robin maintains an independent consultant business, Arvernus, since 1992, helping small nonprofits with process improvements and providing team building and leadership training. Shoba Mittal is the Director of Quality and Compliance, IDD, with the Verlin Foundation, and has served in leadership roles in the areas of research, program evaluation, quality, and compliance with the Southern Pennsylvania region for more than 20 years. She has extensively helped smaller nonprofits in the region with program evaluation and strategic planning needs. Shoba holds a Master's of Public Administration with a gold medal and Master's of Public Policy Management, and graduated as a valedictorian. Shoba is a certified manager of quality and organizational excellence through the American Society for Quality also, and she holds a PA-ODP, Quality Management Certification. Shoba volunteers as the Deputy Vice Chair with the ASQ Quality Management Division, Education and Webinars. She served as an adjunct faculty at the School of Social Work at the University of Pittsburgh for the MSW program. Shoba is fluent in 4 languages and in many dialects, and she is a trained dancer. And so, without further ado, it is my pleasure to introduce Robin and Shoba. The floor is yours.
Hello. Thank you, Doug, for the introduction, and thank you all for attending. Shoba, you want to advance?
It's not happening, Robin. I don't know why. I typically have this problem when I'm doing this full screen.
There it goes.
Oh, there we go.
There it goes. Before getting started with the presentation, we want to set the tone by providing you with some background history. Shoba and I worked for a 501c3 nonprofit human service organization in the Pittsburgh area. My title was Quality Officer Director, and this was my first opportunity to really utilize my quality engineering background in a nonprofit setting in a healthcare environment. I was hired by a COO who was a past executive with a for-profit production manufacturing operation, and he was familiar with the benefits of quality tools use. He was looking for people with quality experience to implement a quality program across the organization. Shoba was our analyst and quality manager. We were still both pretty new to the agency and trying to roll out several quality improvement initiatives. The organization offered over 25 programs to mainly Western Pennsylvania residents, and it included mental health outpatient. This program was having its struggles. Client and billing information was being collected in a new electronic health record system, and staff information was being collected in a new human resource information system. The quality team's collection, analysis, and reporting processes, they were viewed as being like a shining, uncomfortable light on some of the existing problems. However, there were many data inconsistencies. And during this time, we were offered an opportunity for the agency to participate in a design for Six Sigma approach and methodologies for the improvement of an existing process related to the mental health outpatient program. Needless to say, because of the data and process deficiencies, the quality team, which included Shoba and I, were very reluctant at first to see our agency participate. Shoba was assigned from the quality department to serve as the project team on the project team. And she'll go over our agenda for the evening and lead us through the first half of the presentation. Shoba?
Thank you so much, Robin, and thank you, Doug, for the introduction. So today we are going to get into our experience as mental and behavioral health provider to be intentional in redesigning our process, our outpatient intake process, to improve the access of care. And we also were trying to integrate quality into the design of our service systems and also to standardize the existing process. And we'll talk about, how the existing process was fragmented when we started. And we'll also look into how we wanted to expand our access to care from just one site in outpatient to other areas, and then ultimately to implement this across outpatient services. So let's talk about, what was our need. And we had several needs. From the time we got the phone call for the referral into our services, it was difficult to navigate through the eligibility of the client. I'm going to use the word client. And then through the insurance, what was insurance covering, what was the copay requirements, and all those things. We also did not have any written procedures. As Robin said, our new EMR was being implemented. So, as we were trying to adjust to put data where and how, it was also resulting into some data discrepancies, and our data wasn't clean. As a result, the claims were not clean and we could not get paid. And co-pays, again, were not being collected all the time. That was impacting us financially. And providers such as us, we lose money when our clients either do not show up or do not engage with these services as expected. Also, the staff job descriptions, their knowledge and skill all varied by the sites. And the peer coaching model was more prevalent, meaning I'll tell you what I know and we'll go from there. There were no formal procedures or training methods that could help them. Getting the job done was often the focus rather than getting it right. And change is hard. It was definitely harder for us. And one more thing is that, as common with the human services, we have plenty of regulations which are coming from federal to state to county level. And that makes us very difficult, including the recredentialing, if we are going through any licensure, etc., then not by choice, but by out of no choice, the formal quality improvement methods do tend to take up a back seat. While I'm talking all of this, I do also want to mention that it was not like we did not know what we were doing, or we did not have a quality management program. As Robin stated, we did have a quality management program. We were doing quarterly quality management reporting on the key performance indicators. We were providing the county, which is a requirement, a quarterly report on certain areas that they would like to see, which is, by the way, per service area that we have to give. We had quality circles, we had council, and I was presenting to the Wesley board every quarter. We had a research committee, so it's not like we were completely not in the know. It was on the operations side, and especially on the intake at the front end, where things were not working very well for us. So then, the question comes, why did we decided behavior health? Because we were giving more services than just the behavior health. So the point I want to make is that we had volume in this behavior health area, and we had high need, and we had diverse clientele that we were serving. So our outpatient services, they were scattered all through the geographical areas in Western Pennsylvania, and each outpatient was being managed by 3 service lines, and they were the autism, family behavior health, and education and mental health. Just by design, you can see that we had a diverse clientele, and these behavior health services also included the psychotherapy sessions and psychiatric evaluations. Beyond that, the IMR recommendation was also that public sector try testing quality improvement into their service provision. And another thing, the empirical research, very prevalent within the human services, also have pointed out that there are stigma associated when it comes to accessing mental health. Poverty, single parenthood, racial disparity in human services as such were all barriers to access. And last but not the least is, our process started with a phone call typically. And the research also states that if the phone call experience goes well, then the show up rate and the engagement with services improves. And these reasons made sense to us to focus it on the behavior health area. So how did we do it? I will acknowledge that time, our leadership did not want to invest too much money in the new initiative. We did not know how to do this on our own. And, the fear of unknown, it definitely existed. But I think, we got lucky. So we were at this annual conference in Chicago, and somehow, we had the right time and the right collaborators in place. So as it happens often, in the conference setting, we were talking, and we had the research from Clemson University and University of Houston, and we also had Allegheny Health Choices, and of course we were there. And when we were talking, we realized that all 3 partners here had something to gain from this collaboration. So for example, from researchers' interest, they really wanted to find out how a structured improvement method such as Design for Six Sigma would help improve the outcomes, not just in behavior health, but through the continuum of the services. From the Allegheny Health Choices perspective, they wanted to use the project management and formal quality improvement methods, and they also wanted to learn how to implement those whilst giving us all the logistic supports. And of course, we always, we had the high need of redesigning our intake process and of course to learn the new skills. At the same time, we were 2 behavior health providers. Besides us, there was another provider at Denver, and their focus was to improve their billing and reimbursement processes, while ours was to redesign the intake process, and the focus was on improving access to care. Because this presentation is talking about the provider's perspective, we will only focus on Wesley Spectrum services. So now let's talk about our being intentional in this design. What does that mean? So basically, on being intentional, the broader research question was, how does the contextual variables impact the implementation of a formal quality improvement intervention such as DFSS? And what those cultural or contextual variables were, these were the resistance or willingness to change, learning and knowledge creation while engaging in DFSS, learning about the barriers or facilitators of improvement. So basically, these were, how does a formal quality improvement methodology influences the culture of quality, impacts the willingness to learn and change, and the knowledge gain from there, and also what could be the barriers and the facilitators of this change. So our focus was intake process, and we wanted to redesign it by identifying consumer needs and satisfaction levels. We also wanted to understand the staff needs and satisfaction. Besides those, we were looking into procedural requirements such as insurance coverage, the co-pays, the accounts receivable, supervisory roles, job descriptions, skill enhancements to evaluate what quality would look like in each area, and then to design a process. The question that we encountered, and it's often, a point of discussion, is why should we choose DFSS over the Six Sigma, the typical Six Sigma of define, measure, analyze, improve, and control? And the rationale was that the DMAIC is typically used when you want to improve a current process or make incremental changes, when the existing process is not working, it's not meeting the customer need, or not performing adequately, or wasting resources. In our case, we didn't have a process. For this particular intervention, we did not have a process. And therefore, our focus was to redesign a process. And we used the define, measure, analyze, design, and verify within DFSS to build the new process with structural approach for solving problem and building quality into the design of these services. And we went with the cross-functional team to do it. So it was go time. After all of that thought and all of these discussions and our collaborators, I think we were ready to go in September of 2012. And we gave ourselves about 7 months because we were going to follow the project management technique. So obviously we had a project charter. We defined the problem statement that our front end was fragmented, broken, was not working, was also causing administrative inefficiencies. The mission statement was to redesign the intake and the referral process for the outpatient mental health services within Wesley Spectrum Services. And we had the intervention site and we had the control site defined. Control site typically would not receive any intervention at all. And, we tried our hardest that the staff don't talk to each other. And we were somewhat successful, but not completely successful. And we also identified our stakeholders and the core team. So this included our Wesley Spectrum leadership, our collaborators, and everybody. All those were touching this process, whether helping out or actually implementing this process. So on the DFSS, we started with the define phase, and we did a SIPOC, and we did a current state map. As you watch and listen, through the presentation, you will find that even though we were being helped by the professionals and we were following, but we were still learning. So the outcomes were really not that refined as you would expect to be. And I think which is okay, because that's part of how you learn and how you do new things. So on the SIPOC phase, we were starting with the process and then going through the SIPOC, and then we developed the current state map. On the measure phase, we had to do the need analysis. So we did tons of interviews, collected multiple needs that were tied to this process. And then we did the affinity diagram to put them into grouping. And then we did a need prioritization survey. After we had identified some prioritized needs, we established a metrics to measure them, and we collected the baseline measures on it. Typically at this stage, the design would start, but since we were into the redesign mode, we continued to do our brainstorming, benchmarking, and prioritizing design within the analyze phase. And then came our redesign phase, where we did the future state map and we also implemented the new process. And in the verify phase, of course, we collected the verification measures. So this was the SIPOC. I do want to say that, as I said earlier, that it wasn't that we did not know what we were doing. We were familiar with the logic model of the inputs, activities, outputs, and outcomes, and also the influencers. But this was different. This was a new mindset of doing things. So for example, in the intake process, we didn't think that how could the suppliers and customer influence this? And so that was a new way of learning and changing our mindset. So with the focus approach, we went around, finding a problem, organizing a cross-functional team who understood the process. And then we went about clarifying what the process problems are and, what can we do about it. Also understanding what was causing the variation and then starting the improvement cycle. So with this SIPOC and then implementing the discovery remediation, we went on to the improvement cycle. So if you can see from here, these, I'm not going to read every single column, but we had the suppliers. And again, once again saying we did not even understand, that this was the suppliers and the customers, especially the other ones we knew. So we went through all these processes and we completed our SIPOC based on this. And this is what our current intake process. I did mention that our current intake process isn't the best, isn't the most refined, but that is what we did come up with. So basically, I do also want to clarify that, we did not include the consumers, those who were self-pay, meaning they were paying themselves for their services, or if they were free pay. Free pay means that if there is a need through the assessments identified for the services, but the consumer could not pay, then the agency would step in through the donations to cover that cost. Again, there were qualifiers for it, but we were not talking about this because our major problem was that we were not getting the co-pays collected. So we focused on consumers, those who were insured. So when the phone call or the referrals came in, we first made the check if they were insured. And if they were, then we created a consumer profile in our EMR. If they were not, then we referred them to other outside services. Just for your information, in human services, we just don't say no. We never relinquish care. So we always give them the next connection to the services. We just don't wash our hands off. And then, following the process, if once they had created their profile, then we verified with them if they were willing to accept the programs that we were offering within our mental health. There were about 22 service offerings available to us. And if there was a match, then we assigned them the clinician and we scheduled the assessment. And if they were not, then we would refer them to the outside agency. And then coming back to now we are into the measurement phase. So we corrected our baseline measures. And so the average days from open referral to episode means that you have assigned a clinician now. So we were collecting both for the control side and for the intervention side. And again, I'm not going to read the numbers here. I do want to talk about the customer satisfaction a little bit. So we had a 5-point Likert scale with 5 being a higher satisfaction. And what we were asking were the questions, were related to when you first contacted, was the person attending your phone call friendly and courteous? Were your calls and emails answered back promptly? Were the questions answered in a knowledgeable and professional manner? Were you receiving the information that you were requesting and your overall experience, all that? Now, if you see the satisfaction from the 5-point Likert scale is pretty high and higher on the control side. Again, typical to human services. These people need these services so bad that they are so grateful to get the help that we typically have a very high consumer satisfaction levels, especially if you go into the older adults in your service clientele, then they're very nice to you. So they really will not tell you anything wrong with these services, which is sometimes a disservice as a provider, but that is why, we had a very high consumer satisfaction at the baseline level. And then, the bad debt, we looked at the baseline, what those numbers look like on the job duties for the staff knowledge. You can see the satisfaction level were low, again, because, the job descriptions and the training and the skill set, all those were so variant. Then the documentation of outpatient screening eligibility. So one was, was the documentation being done? And the answer was no at the beginning at both the sites. But was it in compliance? per them, yes, they were doing what they knew best, and therefore it was 100% compliance. And then we talked about the average days in account receivable. We also looked into the backup intake coordinator. So there were no backup intake coordinators at both the sites, but the personnel, those who were checking in, checking the insurance and eligibility, up to the billing and filing, all that, and they could see the percentage of the denial rate over there in both the sites. So now we go into the prioritizing needs. And there were 25 staff that we interviewed across, those who were involved in the outpatient services. And there were multiple questions asked to them, and they had to rate every need in terms of if it's a very critical need, and the intake or referral process will not be able to do without it. And so the scale ranged from critical need to highly desirable, nice to have, not important, or undesirable. And we came up with about 46 needs. From these 46 needs, we prioritized 25 needs. And then the staff was resurveyed. And from those came out these 11 highest priority needs that we had to support. So the measures on the staff knowledge, we were really asking them if they knew how to check the eligibility for insurance, and what do they do if there was no eligibility, and how would they check all in-network commercial insurance eligibility online, and what would they do if that online portal was down. How would they explain the coverage and benefits to the client, and especially in the language that they would understand, in simple language? And how would they explain the copay requirements upfront? How would they check the medical assistance and managed care eligibility online, and what would they do if the online portal was down? So these were the questions that the staff knowledge was being researched on. Robin, over to you.
Thank you, Shoba. I was called in at some point to do a couple of root cause analysis with the group to address what boils down to the effect that the access to care through admission and enrollment processes needed to be redesigned. Why? As mentioned in previous slides, timeline issues, multiple clinics, multiple staff, differences in processes, difference in documentation, there were billing issues, and is incorrect information entered into the electronic medical record. Next slide, Shoba. Now, this is a busy cause and effect diagram, but it was done to help evaluate more of the staff duties by focusing on another effect, which was why work is not completed with quality, completed effectively, or completed in a timely manner. Now, some of the answers to the whys included can be directly associated with the why access to care through the admission and enrollment process was broken. So, for example, why differences in referrals, customers? Why are there differences in staff who put in the information? Why is there a new electronic health record system and they're having issues? It's related to updates. People weren't getting trained properly or able to access the system in general. Was there limited space within the building for the intake personnel to work from? External changes were taking place that affected the process, like CPT code changes and changes to the electronic medical record. There were form differences. There were perceived program differences, as mentioned before, billing process, and it was mentioned that the program budget commitment was too high for program productivity projections. They were just basically unrealistic. Now, this budgeting comment stood out to me because this came up often during a discussion, and certain participants mentioning the whys concerning to staff cutbacks, financial goals not matching staffing expectations, and financial projections not being met as proposed. During the discussion that followed the cause and effect session, approximate cause was noted about staff, but without a direct correlation to the budget or budgeting process, but more to skill and understanding the process. Next slide, Shoba. Some of the resolutions based on discussion with the agency leadership and the Design for Six Sigma team considered resource allocation and standardization of processes. Well, what is practical when it comes to achieving work that is completed with quality, effectively, and in a timely manner, and what was not practical. And as you can see from this slide, it was thought practical to cross-train staff, to reevaluate staff job responsibilities who were assigned to the intake, as well as what the job would entail for greater success. Hiring staff was not considered practical at the time, nor was creating a temporary staffing pool. And we definitely did not want to delay getting back to the client. Next slide. So the team got together to solicit ideas about how to meet the top rated needs. Some questions asked the participants included, how do you or how could we increase customer satisfaction related to receiving timely access to services? So as Shoba mentioned before, the customer satisfaction was relatively high, but customers still weren't able to receive services in a timely manner. How do you or how could we effectively document the insurance eligibility procedure process? How to ensure prompter cash flow by reducing the amount of time that fees are in accounts receivable? What types of things should be standardized in the intake process, no matter where intake took place or no matter by who handled the call? There were also discussions on a few levels about staff training. Next slide. Now, the next step in the Design for Six Sigma project was implementation. What should be some of the project deliverables? A written copay policy, to redesign the financial responsibility document, for staff trainings to be developed, for staff job descriptions to be changed, and to create documents in the EHR, in the electronic medical record, for a process ease. We wanted to develop protocol when backup staff would be needed and to clearly communicate the changes to staff, including all staff that would be impacted by the change. The next two slides show what we hoped for as a redesign. Actually, just having a diagram to document the process flow allowed for a smoother transition, something staff can follow to help expedite the interaction, as well as demonstrate standardization of the intake process. Insurance review and the benefit explanation, first visit or no-show, and a check for customer forms and their first actual visit. So these two slides really did, you can go to the next slide, Shana, Shoba, to show the other part. These two slides really did show the process flow from the first call to when the consumer was actually put into care. And it gave the staff an opportunity to really have something to follow. Next slide. So measures were taken prior to the project, and they were reevaluated, including how long a consumer had to wait from first call to first visit. So we see here that the access to care increased by 43% from a wait time of 8.6 days to a wait time of 4.9 days. The consumer satisfaction remained high. The bad debt and uncollected funds decreased by 81%. It went from $21,991 in the third quarter of 2012 to $4,073 in the fourth quarter of 2013. Cash flow improved because of the reduction in insurance denials, and staff felt more confident about the progress and the way that they performed in their job, and knowing that they had redesigned job duties. Next slide. Oh, you advanced. That's good. Thank you. Of course, we wanted to capture the limitations of the Design for Six Sigma approach and the lessons learned. So some of the limitations, the one that stood out is that no behavioral health examples in peer-reviewed literature could be used to benchmark where we were for the Design for Six Sigma. It also was limited with staff resistances, Shoba mentioned previously, to the changes. And the takeaways that we got that were positive, that the Design for Six Sigma works in social service industry. Staff were able to buy into the structured approach because they were a part of the redesign process. They were able then to take pride in the way that they could see that the changes had taken place overall, and the fact that the redesign really did improve the process. Next slide. So our current state today, as a merged entity with another organization, the agency has over 45 service areas and 18,000 service recipients that come through the door. 25 service areas are coming through a centralized process of intake, and we call that central access. They average about 30 calls a day, and they operate 5 days a week. Information is collected from first call, and that includes age, assigned gender, the geographical location, how they heard about the company, along with additional information. The insurance type, the staff were fully trained on collecting information with regards to insurance, as well as status through quality circle meetings. So we go over this data at quality circle meetings, and we have continuous discussions. So that ends our presentation, and we're ready to take questions.
Okay, thank you. We're still getting a few questions in here. Yeah, I'm going to go ahead and let's see. I need to. Yeah, here we go. So, does anybody else have any questions? We've had one here. Okay, the one question we did get so far. So it's from Vincent. He said, what was the change management strategy that you used for your staff engagement?
That's a great question, Vincent. It was maybe a few years before we even went with the Design for Six Sigma that the agency participated in change management called ADCAR, where staff were trained in making sure mainly that other staff were aware of what was taking place, and that it was fully communicated across the organization. They had knowledge of what it meant, and that way we were able to get buy-in, and not just from middle management who were responsible for some of the intake personnel, but from the intake personnel themselves. Shoba, you want to add anything?
Yeah, I do want to. Thanks, Robin. I think one of the thing also is that again, I will say that which is common to human service industry, and I think these days in many industries, is that the attrition. It's difficult to hold staff in. So those who went through the change management, they were not there. All of them were not there when this was being implemented, and therefore and even if they went through the training, we all know that when we learn new things and if the time passes by, we kind of lose some of it, and therefore we did have that resistance despite the change management. So both the things were true, that yes, there was a formal change management process in place prior to this, but again, staff attrition is responsible in a way for not that knowledge learned not being so effective.
That's
Okay.
right, Shoba. We did lose some of those individuals that went through that training, and you're right. There still remains some resistance in the process.
Okay. Thank you. Um, so, oh, now we're getting some good questions. Um, so here's one from Zach. Have you used Design for Six Sigma on other projects? And are there any general lessons that you learned out of this project? Things that you learned that you might apply next time?
So we have maybe not the full Design for Six Sigma format, but some of the tools that came from it, working the affinity diagrams and using SciPoc. Some of the same tools have been used going forward on other quality initiatives.
Okay.
And I think that one of the key thing that we learned from this implementing this design for Six Sigma is that we brought the teams and we asked their perspective. So, those who are involved in this process, hands on, were given a chance to voice, because the leadership knows, yes, but nobody knows the hands that are in the pot. So this gave us the opportunity of asking and really getting to the core needs in the process, and that helped us really to improve the process. And the other thing was that despite after this was all done and completed, that knowledge sharing did happen. So, when we looked into the before and after, there was some increments even on the control side. As I said, we tried that the staff don't talk to each other, but some spill was there. And we did find that, there was improvement even on the control side, despite them not participating that actively. Um, yeah, that's it.
Okay. Um, yeah, I think one of the questions was, has staff turnover affected it? And I think you answered that already. Um, so another question here was from Melissa. She says, do you have any comments to make on addressing grievances with employees in the healthcare industry in general? She's thinking about parallels lately between her experiences working in the ER when they wanted to strike under a hostile takeover, implementing changes that we could not accept. And she's also thinking about the current railroad strike crisis right now. So what do you think about that, addressing grievances with employees?
So could you repeat her example again, please, Doug?
She said that her experience was working in the ER, and the ER wanted to strike because there was some kind of a hostile takeover, and they were putting changes in place that the ER staff could not accept.
I'll take
So
this, Sorry, go ahead.
no, go ahead, Shoba. I'll tag team.
Okay. So I currently work in the healthcare industry, like not exactly like it's still a human service, but um, um, we do provide the medical and the nursing services in-house. So I think what happens is that it is so important to pay attention to the employee grievances for the very simple reason is that it's very expensive for the organization to hire staff and then to train them before they become fully productive. So that is one reason to pay attention to what they're saying. And I think, this is the other thing is that not just listening, but also doing something. And what formal procedures do you have in terms of, how do those grievances come in? Who listens in? Is it only an HR responsibility versus it is, where your supervisors are involved in it and you take actions proactively? And I think, that is the need of the hour, especially this, post-COVID area. Attrition rates are pretty high. People are leaving jobs or they have left jobs. So it is important to retain and make your employees feel wanted and respected and needed. And I think one of the mechanisms is to pay attention to what they're saying.
Thank you, Shoba. I just wanted to add one thing, and that is that our department does handle grievances, but mainly the client or service recipient grievances, that the other grievances that are handled through employees are done more with HR, and we do partner with HR on those grievances that come from employees because sometimes they feel HR as part of the overall company or system, and they view quality as independent and objective. So that gives us some leverage when we're working with HR as a partner in the grievance process.
Okay, thank you. That's interesting. I've not heard other places where quality plays a role in internal disputes. Here's another one. So was there anything about the call center specifically? Did you work at the call center? Were there any Six Sigma applications used there?
So I think that's a really great question. So there was no call center per se when we first did the design for Six Sigma. It was more of just staff that were had the responsibility of doing intake.
Mm-hmm.
Since that time, though, now that we have the central access, it is more like a call center where the individuals who do the intake are together and or have access to one another, so that if there's any questions, they have the ability to have a dialogue and communicate with each other to better answer any of the consumers' concerns or to help direct them in other areas if need be. Shoba, I saw you ready to chime in. You have something you want to say about that as
No,
well?
Robin, it's been a while since I left Wesley Spectrum, so I don't know. I remember that we didn't have a call center per se, what you just said, but I do not have anything to add.
Okay. Um, here was an interesting one. Sam asks, how do you convince the top management to buy into such a redesign program? Um, were there any assumptions made um, before you implemented it that may have influenced how management bought into it?
So I love that question because it was the um, CEO and some of the program folks that the program officer that really wanted to work with the design for Six Sigma. I was a little more reluctant, and the COO, who also had come from a more of a quality oriented manufacturing type process area, was reluctant as well. And then the reluctance wasn't because we weren't interested in trying something new. It was that the thought of Six Sigma and the need for clean data was a deterrent for the quality folks. But once we had learned more about it and had the partnership with the other team members in this Design for Sigma, and really got it started through the help of our, I'll call them facilitators through AICI, was really able to see some of the benefits from it.
And I would agree with that, Robin, because I think upfront what the hesitation from the top leadership was that because of the cash flow issues already existing in this process, they were not ready to invest more money. And secondly, I think as I mentioned in my presentation very early on, that we didn't have the capacity to really redesign and do what we wanted to do. And the third thing is that there was always this, what are we getting into, and maybe we come out as worse, not better. But I think with the collaborations and their expertise and the meetings with them, initial meetings with them before we started that, did convince them that we had nothing to lose, really. We were not incurring money. We were getting all the support and all the knowledge, and we would only learn new things and perhaps at that time improve the process. And I think that was convincing.
Very much so.
Okay. So, we're getting quite a flow of questions here, but the one just came up that I think might be a really wonderful one to finish with here. Maria asks the question, which of the outcomes that you saw after your verification phase was the most surprising to you?
I would say the overall savings. Once we were able to go in and have people participate and go through some of the trainings, I would say that the one of the biggest accomplishments was the overall savings.
And I want to say, besides the saving, is the staff ownership, because they were involved in the process, because they had the say, which was new to many of these intake staff, and they had the formal training, so they had the tools, what was needed. So that ownership, that discovery of new ways of doing things, and then the ownership of it, I think that was hugely impactful, even in continuation of this process to improve as we moved along. So that would, I think that buy-in and that ownership, despite the initial, saying, no, I don't want to do that, resistance to change. But I think once they were involved in a meaningful way, it was a win.
Okay, wonderful. This has been just a marvelous talk. Thanks to both of you for doing this. We're going to do a couple of closing items here. First of all, I'm going to remind everybody the email addresses here are. You may contact them if you had a question and it was not answered.